Hola, señor. Another thing I forgot to mention about past section. Can't remember what it was. Did I miss something? I can't find it. It was in my head. Now I forgot. Did I miss something?
What happens to the fetal part abdominally? Is it easy to palpate or difficult?
When it comes to uterine rupture, you're talking about?
Yes.
Yeah, it'll be difficult, no?
Why is that? Some places it says easy, some places it says difficult.
Don't know. Depends on, I think, the how much is the how much of the uterus is ruptured. Ne? I'm not sure. Does anyone know? Okay. Yeah, someone check that. The next one
In the
is.
guideline,
Yeah, what is the guidelines?
in the guideline, other clinical signs indicating uterine rupture, there is loss of the presenting part on vaginal examination and disappearance of fetal parts.
Yeah.
Meaning like you can't feel the fetal parts.
Probably, no? I have to check that. Okay. Next one is abnormal presentation. So that means the child can be in transverse or breech. So what would you ask in the history, Shalka? Shalka?
If it is breech, I would ask at which POA it was detected, because if it was be detected at early pregnancy, there's a chance the baby will would have turned by now. And then what were the investigations done, like external cephalic versions were tried, or if not tried, why they have not tried it. Placenta previa or any fibroid in the uterus. Last size of the baby.
Yeah, amniotic fluid.
Polyhydramnios.
What else? What are you asking the mother if she has polyhydramnios?
If he has diabetic, then they could have polyhydramnios, macrosomic baby.
Yep.
Yeah, no, that's it.
Yeah. Then fibroid, if he has any congenital anomalies detected in the scan, that could change the presentation. Then the placenta location, and why she's admitted for, if she's admitted for confinement or if she's admitted for C-section. I mean, C-section is confinement, or if she's admitted for ECV. So, yeah. If it's a early presentation with breech, important things you have to exclude is this fibroid, placenta previa, and then you reassure. And then in 34 weeks, if it's also breech, you can wait till 36 weeks. At 36 weeks, when you can do this, usually you do the ECV. Yeah, almost everyone can undergo ECV. There are contraindications ECV, like if you have multiple pregnancies, polyhydramniosis, and placenta previa, then best you can't, or IUGR, you can't do ECV. If you are a primary mother, then ECV is done usually at 36, multiparous at 37, and then when you are doing ECV, you can get complications like fetal bradycardia. Sometimes there can be cord accidents, fetal-mater hemorrhage. There's also slight risk of abruption. So can you tell me the procedure on how to do ECV?
I don't know. I think it's abdominally. You rotate the baby, you hold the baby one from the hand. And first of all, you have to do a transvaginal ultrasound scan. And then
Mm-hmm.
you have to keep your, I don't know, maybe
What you have to
left
do
hand on
before
the,
all
you
that?
have to do a CTG,
Good before CTG.
ultrasound scan, to see the location.
You have to admit the patient. You can't like do when she's walking the ward. You can't do ECV.
Yeah, yeah, okay.
Yeah, so admit and then do a CTG before. Some say you have to fast. Some books say you don't have to fast. So I'm very confused on that aspect. Apparently, you have to
Why
fast
don't
6 hours.
Because if there is emergency C-section,
Yeah, probably. That's why I think you have to fast. But some say you don't need to fast. So I'm not very sure. So and then other thing, is there any drugs you can give? Tocolytics you can give. And then yeah, after the ECG, do ultrasound
not
scan. And
always, right?
not always,
Do
but
we
you
give
can give. You can. There's a place for tocolytics also. And then CTG again. And the success rate of ECV, do you know?
50% is the success rate. Can turn back 5%.
Yeah, success rate is 50% and return to breech there's a risk of at least 5%. And then the types of breech, you all know, extended, flexed, and footling. And then they can ask about the breech delivery. Important things is sent to labor room, maintain the partogram, and usually you don't do a breech delivery. But if the mother comes with a cervix of 10 centimeters, then you can consider breech delivery, but best not to do it. Only instances, example, is if it's a twin presentation. If the first twin is
Second twin.
cephalic, huh?
Second twin is breech.
Yeah, yeah. So if first twin is cephalic and second is breech, then only you can do a breech. That also, if the second twin is larger, then sometimes it might lead to problems. So yeah, but usually it's in twin. You should not do it in primaries. And then adequate pain relief is important. Then CTG. Avoid doing a ARM and be careful when you're augmenting. And you only intervene in 3 areas. One is the sacrum, other one is the inferior border of the scapula, and the nape. So in breech, you notice the breech when the baby is climbing. That is known as, if it's cephalic, it's known as crowning. The climbing is when the breech enters the introitus, and then you have to do maneuvers only if there is when you only intervene again when you see the sacrum, inferior border of the scapula, and the nape. So if the mother is in footling breech, you have to go for C-section. But if she's in flex breech, again you don't have to do much. The legs will automatically come out. In extended breech only, you have to do the Pinard maneuver where you press the popliteal fossa, and this would make the child legs to flex, and then you take the legs out. And then when you see the inferior border of the scapula, you do the delivery of the hands. So if the hands are flexed, you can do the windshield wiper method where you move the hands across the torso and take it out. And then if the hands are extended, you can do the love set maneuver. That is like in the shoulder dystocia, you turn the baby by 180 degrees clockwise and anti-clockwise basically. And then in the nape, you can do 3 maneuvers: Burns, which is not usually done, and Morrissey's melee, where you put your one hand from underneath and other hand on top, and you put it in the malar uh, area, and you flex the hand, and you press from the occiput the other hand, and this would reduce the presenting diameter of the head, and then you take the baby out. And otherwise, other option is the Piper forceps. And Then there are other abnormal presentations like face presentation. Mento anterior you can deliver, mento posterior you can't deliver. And when you are doing a face presentation delivery, there is risk of facial nerve palsy in the baby, facial bruising, and also a risk of cord prolapse. And that's about it for abnormal presentation. And then fibroids also can lead to abnormal presentation. Then also it's best to do a C-section depending on the location of the fibroid. I'm not entirely sure. I think if it's upper segment fibroid, you can't go for normal vaginal delivery. But if it's a lower segment fibroid, you can, I think, consider doing a normal vaginal delivery. The best option is a C-section.
No, the other way around. The other way around. If it's a
Further.
lower segment, lower now fibroid, you can't go for the delivery. The obstruction can happen.
But most muscle contraction occurs in the upper segment. Lower segment? Oh, let me check.
Baby can get obstructed if the fibroid is below. Not because of the contraction, it's because of the obstruction.
Okay. So then if it's lower segment fibroid, then you go for a C-section, and upper segment you go for a normal vaginal delivery. Where is it? Is it there in the guideline? Salka.
It was there in a
මේක සාමාන්‍යයෙන් fundus more than POA නේ.
No.
Let me check. Elanti madam. Yeah. And if another thing about fibroid is the rate degeneration can occur. And here then you just manage conservatively and give antibiotics like ampicillin. Yeah. So if fibroid is below the presenting part, you can't do a normal vaginal delivery. Yeah. And then another important thing in fibroid is there's high risk of PPH, so it preserve at least 2 pints of blood. Other indication is if it's a broad ligament fibroid or cervical fibroid, you have to do a C-section. Okay, then diabetes in pregnancy. Okay, Uda?
Yeah.
What did you ask? His mother comes at 36 weeks with diabetes. What did you ask in the history?
At 36 weeks. So basically, you need to ask and see if she has had diabetes before she was being pregnant, and booking visit investigations, like what was being done, like what was done and how they were. Then also, if it wasn't, you should ask about whether it was diagnosed at the 28-week OGTT. And in anomaly scans, in someone who has had pre-existing diabetes, if in anomaly scans there are any congenital anomalies detected. And apart from that, about the growth scans, and if at clinics at any point whether she was told that that her fundus was more than the dates, and if in previous pregnancies she has a GDM, and if she was on high dose of folic acid before that, and also in the after the first trimester in someone with pre-existing diabetes, in the booking visit, if if they had pre-existing diabetes, if the drugs were changed, and also at whether they have been screened for nephropathy or retinopathy, and also like after 20 weeks, the growth scans were done to see the growth of the baby, and Also to see if the presentation of the baby at 36 weeks scan. Uh, and also in the previous pregnancies, what was the mode of delivery, whether the children were macrosomic, and if the children, whether she had complications like after having the children, like during normal vaginal delivery, like shoulder dystocia or prolonged labor, or if she had any instrumentation. Uh, and also in the current pregnancy, you should ask and see after the diagnosis of diabetes, how is she monitored, whether she has done blood sugar series or whether she did self-monitoring, and if she was started on medical nutrition therapy, and is she only on metformin, or is she also on insulin, or is she also on any additional drugs, and uh,
One
yeah,
more
that's
thing
all I
you can
can
ask
remember.
in the booking visit or in the 28 weeks.
Thing you can ask in the booking visit or the 28 weeks.
Yeah. Or in routine screen channel clinic visits.
No clue.
You can ask about if she had any associated hypertension. I don't know if you told
Ah,
did.
no, I didn't tell. I
Yeah,
forgot
so
that.
because,
Ah,
yeah.
okay.
Yeah, that, what you told is correct. And then you can ask about the values of the recent blood sugar series. If she folic acid dose was increased, so small one.
Folic acid, like you
Only if it's
increase it
chronic
if only
diabetes.
they had only if it's
Chronic diabetes, you increase it to 5 milligrams in the first trimester. Okay.
Otherwise, you don't need, no?
Yeah, otherwise it's 1 milligram.
Okay, thank you.
Yes, sorry. The normal folic acid, the preconceptional folic acid dose is it 400 micrograms or 1
No,
milligram?
1 milligram. 1 milligram. Ne?
1 milligram.
But
400
some
is enough, but
places
they
say
give 1
400
microgram.
micrograms.
Whose book?
400 is enough, no? But 1 microgram, 1 milligram is what they give usually.
Yeah. And yeah. Then on examination, you can ask about the diabetes features, the build, the BMI, acanthosis, pregnancy changes, linear nigra, flat umbilicus, increase of under height, like a volume. And how would you screen for this diabetes? What are screening tests?
That at the booking, if you're going to screen, we can either use HbA1c or postprandial blood sugar, or else we can use OGTT or OGCT. But in the first trimester, OGTT and OGCT are not that convenient for the mother. So usually we go with a HbA1c or PPVS.
It's not the convenience, it's the cost, I think.
OGTT. I thought
No,
HbA1c is
No,
more
I think
expensive.
because she's having pregnancy symptoms in the first
Yeah,
trimester.
nausea.
Yeah,
She has
nausea vomiting.
cost එකක්
vomiting and all.
dollars issue no?
කොහොමද තියෙන්නේ?
HbA1c expensive, ne?
Yeah.
Why won't you do HbA1c in the second trimester or third? Any idea?
One of the because in the second and third trimesters, the lifespan of red blood cells get altered, so HbA1c can
Yeah.
give a wrong value. So instead, the
That's the
serum
main
fructosamine is a better test.
Yeah, or else you can just do the OGTT.
Yeah.
Or you tell me the OGTT values?
Fasting should be less than 100. First hour less than 180. Second hour less than 140.
Postprandial blood sugar?
Postprandial blood sugar, first hour it's I'm not sure it's 200 or 180. Second hour it's less than 140.
PPBS is 120, right? It's just after 2 hours, no?
120 is the blood sugar series, no?
No, PPBS value after 2
Second
hours.
hour?
Yeah.
Then first hour?
Second hour is, I think PPBS you do it after 2 hours.
Yeah, 2 hours.
Isn't
There is
the
no 1
1 hour
hour,
value?
2 hour value. It's 140.
Ah,
ne?
shit. Yeah. My bad.
Yeah,
Yes,
you're talking
yes,
about
yes,
blood
yes.
sugar series.
Yeah.
Yeah, it's 140
PPBA has
after
only
2 hours.
140. Yeah, 2
Yeah.
hours.
And there's another thing. I think if you're screening, if the PPBA is 140, then you have to diagnose with the OGTT. If it's above 140, if it's above 200, that means diagnosis of diabetes. There's something like that also,
So
I
can you
think.
repeat it again?
So there are screening tests and diagnostic tests. No? So let's say fasting blood sugar, let's say you do it in the booking visit and it's like 103. That means it's either diabetes or pre-diabetes. So it is a screening test. So in this case, the screening is positive. But if the fasting blood sugar is like 150, that means it is diagnostic of diabetes. So for postprandial blood sugar, if the screening test is positive, means if it's above 140 to 200, then it's like either pre-diabetes or diabetes. No? So if it's about 200, then it's diagnostic of diabetes. You got it, or did I make you more confused?
More confused.
And then forget
Uh,
it. Yes, I don't want
Yeah,
to.
fasting blood sugar, we don't do fasting blood sugar in
yeah.
pregnancy.
OGT data කරනවා නේ. Booking visit
The
එක you can do,
fasting
no?
is not
OGTT එකට
used.
කරනවා. ඔව්.
In the booking visit also you
Yeah.
do. Some others do, no?
Fasting is
නෑ.
not recommended for screening.
ඇයි
In
එදා
booking visit
බැන්නේ
even.
අපිට මෙයා කවුද? නිලන් සර් after
මොකටද?
taking fasting blood sugar එකට booking visit එකේ.
Sure.
කරන්නේ PPBS එක තමයි කරන්නේ.
Then Target, tell me the diagnostic test.
There's only 3 tests are screening: no? OGTT, the OGCT, and the PPBS.
PPBS.
Others are not recommended. So HbA1c, fasting blood sugar, random are not recommended for screening. So a
Means-
PPBS, I mean, what is done at UHKDU, apart from Nilan sir, what the others do is a PPBS. If that value is more than 120, then they do a OGTT at booking itself. Now Suranga sir and Tilak sir at NFTH, they straight away do a OGTT at booking visit itself at NFTH. The recommended thing is the OGTT at booking visit, but because it's a process to do, meaning if you do the postprandial, you can straight away keep the mother at the clinic that day itself, not fasting, nothing.
Yeah.
Have her do a sugar test after 2 hours, and then if it's positive, do the OGTT if necessary. OGTT, she has to be fasting, but the ideal setting is to do the OGTT at booking itself. That is the gold standard screening test.
At booking, isn't the HbA1c better? I think
Only
Booking
Milan
you
sir,
can,
from
yeah.
all the fellows, only Milan sir does HbA1c. At booking
Yeah,
sir,
exactly.
still diabetic mothers. Yeah.
Can you see this? The guideline?
Yeah, can see.
So diagnostic criteria, it says fasting blood sugar above 126 in the guideline. So
Hi, but this is now for to
Pregnancy.
diagnose people on diabetics. This is this is pre-pregnancy diabetes, right? This is not GDM. To make a diagnosis of GDM, the
GDM
gold
you need to do it
standard
at
would be a
28 weeks.
OGTT,
Yeah.
but
Yeah.
OGTT at
28 weeks.
least 16 weeks, the earliest to make a diagnosis of GDM.
Mm.
Yeah, earliest you can do it to confirm GDM is 16 weeks, like Ajinda sir said. So, but you can also use the OGT to diagnose pre-pregnancy diabetes or any form of diabetes in pregnancy. It's
Yeah.
just that
So
if it's
fasting
before
blood sugar
16
has a
weeks, it's
place,
more
no,
likely
it's
to be
not contraindicated.
undiagnosed chronic diabetes rather than GDM.
Fasting blood sugar you can do it, but it's
For
not
screening, it's
recommended.
not indicated. You shouldn't do it for screening. Yeah, you can do any of the tests, but what is recommended for screening is the OGTT, OGCT, and the postprandial.
No?
2 hour postprandial.
Okay. Is it there in the guideline?
So now the section you are looking at now is the
Recommended test, no?
the very
OGCT.
beginning it says some separate to screening. Yeah.
Yeah. So this one is OGCTT. Other one is this 3-point oral GT. I think that's the blood sugar series. No,
No, the 3-point OGTT
3-point is the normal one, no? Yeah.
The normal OGTT. That OGCT, the 1.1 is DIPSI. That is the DIPSI test. So that is used in low resource settings.
Yeah.
Like India and places like that. They use the 1-point test because they want to diagnose people immediately. Because if you tell them to fast and all and come back, you might lose them to follow up.
Mm-hmm.
So they do that non-fasting 1 point OGCT. So that is different. That is not done here. We do so what the ideal thing that is done here is the postprandial at booking. If that is more than 120, then they do a OGCT. Sorry, OGTT. And then again, that OGTT is repeated at 20 weeks also, 28 weeks also.
Mm-hmm. But if it's diagnosed, you don't repeat it in the booking visit?
If they are already diagnosed before,
Then no point.
it's recommended to do an OGTT also. So no point
No,
because
ne?
you already know, but you should do. I mean, if they are already known diabetics, then you don't do OGT. So I mean, you already know. Then
Yeah,
you have to
exactly.
do HbA1c and things like that to see their previous control and things like that.
Mm-hmm.
By doing
So,
OGTT in the booking visit, you're trying to identify previously undiagnosed diabetics, if at all.
yeah. So the tests are the postprandial blood sugar should be 140, no? And then the OGTT, that is 100, 180 by 140. And then those are the recommended tests, right?
That's the thing. This 140 is the DIPSI test. But just doing a postprandial, it should be 120. In a little down when you go, it says the
This
next
one,
section.
no?
It says 120 is the cutoff to do a OGTT if your postprandial blood sugar is high at booking.
Mm-hmm. The postprandial is 120, no? Not 140, right?
140 is the DIPSI cutoff.
What is DIPSI? What is this DIPSI thing?
DIPSI is the one stage, the first box.
Mm-hmm. Yeah, muted.
Sorry, yeah, no, we presented a presentation to Achinta sir and he only clarified these things from he only told us about this. So he said that if we're asked, there are lots of different values, even the cutoffs now, some of you all said 120, 140, 180.
Exactly.
So those are not the HAPO study values. There is this International Association on Diabetes in Pregnancy study group, the IADPST values. They have done this study called the HAPO study. So HAPO study cutoffs are more suitable to our region. So ideally we should follow the HAPO cutoff values, which is
අමුතු values
92,
92,
fasting,
153 ඒවා නේ.
92, 153 and 180. Sorry, 92, 180 and 153.
Yeah.
So the thing is, in the setting, like now midwives and all, when they go and check, like now when mothers take these reports privately and stuff and come, for them to refer them for referral, it's easier for them to remember 120, 180 and 140, and those values rather than remembering odd numbers. So that's why that is still in talk. But ideally, if to make a diagnosis, it should be the HAPO criteria.
But they use both. It's just you have to be more wary when it's like in the middle between the
The HAPO එකේ 120 ppb තියෙන්නේ.
No. The HAPO one is the OGTT criteria for fasting 1 hour and 2 hours. So fasting is 92, 1 hour is 180, 2 hours is 153.
Okay.
Our national guideline says to take 120 for now when you come for a booking visit, you just do a postprandial blood sugar rather than doing a fasting full OG 75 gram OGTT. Rather than doing that, you do a postprandial blood sugar. In 2 hours, you check the blood sugar. If it's more than 120, that's an indication to do a OGTT. Then you do an OGTT only and confirm diabetes. If it's at the booking visit, so then it has to be pre-pregnancy diabetes. Now, if it's at 28 weeks, then you can diagnose DDM.
Okay. Can you tell me the pathology of GDM? Anyone?
There are increased circulation, increased amounts of human placental lactogen and other hormones that promote growth.
Cortisol, prolactin.
Yes.
And in GDM, there is less beta cell reserve of insulin.
Yeah.
And in GDM, the basal insulin is normal, but you can't maintain an increased insulin requirement. That's why this OGTT is positive. So, yeah, how would you manage if there is elevated blood glucose in the booking visit?
So first off, it would depend on how much the blood values are elevated. Like what's the if they're massively elevated, like 200 plus, 300 plus values, then straight away I would go for medical management with drugs. So first thing is I would like to follow this woman up every 2 weekly. Then so I would first, if depends on the sugar values, if the sugar values are just over the upper normal limits, then I would first go for medical nutrition therapy. So medical nutrition therapy consists of both dietary and exercise related advice. And I would monitor her with 2 weekly blood sugar series values to see how her sugar control is. So if first off, if her values were elevated, I would have to see if it was, if she's, that is at the booking visit, you said, right? Elevated. So then I have to do an HbA1c there first and see what her past control was like. So this is not GDM, this is previously undiagnosed diabetes mellitus.
Yeah.
So I do a HbA1c and I can admit her to the ward for a 4-point or a 6-point blood sugar series also. And depending on, then I can send her to the nutrition clinic for medical nutrition therapy also at the same time, and do a assessment of her blood sugar control to determine a regimen of drugs. So if
how
the
much
sugar is, I don't, is there a cutoff? Is there a cutoff?
No, 120, like you said, after 2 hours, after a meal, it should be less than 120. If it's more than 120, you have to consider changing the management.
No. I mean, there is no cutoff to start drugs, though, right? I mean, if it's very massively elevated, you can then straight away go in for
MNT, and there is no. You have to prefer to endocrinologist probably.
Sorry.
You need to do a MDT approach if I to a physician or endocrinologist for further management probably.
Yeah.
Usually you just start simply MNT, then metformin, then insulin.
Yeah.
What other 2 drugs would you give?
Apart from metformin, insulin, glibenclamide also can be used. No?
But what else would you start in the booking visit if there's elevated blood glucose? I told him before.
Aspirin is one.
Aspirin and?
Aspirin at 12 weeks it should be started, and what else?
Folic acid you can increase 5 milligram you can give.
Yeah, to 5 milligrams, no? Yes.
And then when it comes to delivery, you deliver at a tertiary, well controlled 40 weeks, medical nutrition therapy 39, and metformin also 39, and then insulin and well controlled 38 weeks.
Sorry, what do you mean by 39?
39 weeks period of
She's on
gestation.
metformin.
Yeah.
Okay. No, you said metformin 39. I mean, if she's only on metformin, deliver at 39.
Yeah.
Okay.
Poor control 37 weeks, can do a normal vaginal delivery. GDM is not a contraindication for a C-section, and then you have to inform our senior house officer and monitor the blood glucose hourly. If there is problems in monitoring, you can use a sliding scale. An important thing during deliveries, anticipate complications like postpartum hemorrhage, dystocia, and even fetal distress. And then after delivery, you can repeat the OGTT in about 6 weeks postpartum. That is if you suspect it's GDM. If it's chronic, then also then I don't know if you do it again. If it's chronic diabetes at booking visit, then need no point doing a repeat OGTT at 6 weeks. It's an indication. Or is it only if you diagnose at 28 weeks?
You just go back to the pre-pregnancy medication. Diabetes.
No, you do a OGTT again at 6 weeks.
Yeah.
No, sorry. If she was a known diabetic, right? That is, then no need. Then you go to pre.
When do you give insulin in labor? Is there like a particular time? No. Just
Yeah,
during labor, you may
insulin is
monitor it
given in labor, no? It
during
depends
labor,
on
no?
the blood sugar values during
Yeah,
labor should be maintained between 4 to 7 millimoles. So if it
yeah.
is more than
I
7, you have to give a glucose dextrose insulin dextrose potassium drip.
yeah. And then you're inform the neonatologist because there's risk of fetal hypoglycemia and all that. Okay, and then after delivery, Meow's chart. Don't forget that. What is the definition of GDM? Does anyone know? Ashay, do you know definition of GDM? Apparently, it's any degree of glucose intolerance in pregnancy which resolves 6 weeks postpartum. And you should know the complications that can occur if you have diabetes in pregnancy. Mother complications, you are more prone to get pregnancy-induced hypertension, retinopathies, postpartum hemorrhage, and diabetes mellitus in the future, as well as infections. Fetus, you have higher chance of intrauterine death. Sacral agenesis if you are chronic diabetic. Macrosomia, polyhydramnios, congenital defects, jaundice, polycythemia, and then during labor you can have prolonged labor. You might also have to undergo lower segment cesarean section. You might need to do an instrumental delivery, and there is increased risk of perineal tears. So it's about it for diabetes. I will do hypertension and three more topics. Okay, and we start.